Welcome to the weekly series of Caring Conversations Empowering Lives for Cancer Care. In this series of events, we come together along with eminent experts in the field to discuss and empower cancer patients as they fight their battle against the disease. In today's event, we will first take note of a recent finding that has identified a new gene connected to hereditary breast cancer. This researchers are terming as a landmark study. Then we will hear from our distinguished guest, Dr. Emily Banerjee, on why and how genetic testing helps estimate your chances of developing cancer. We would encourage you to ask questions to our experts by typing in the comment section. We will take them up at the end of this session. Let's begin with today's session of Beat Cancer Facts. Some of the risks for breast cancers, such as diet, exercise, or hormone medications, are preventable, but others, like genetic mutations, cannot be changed. It is already known that some genes can predict the likelihood of breast cancer. Women with a mutation in the BRCA1 or BRCA2 gene, for example, have a 70% risk of developing the disease. This is a statistic presented by the American Cancer Society. So, some of these genes are already known to make women predisposed to breast cancer. Now, a paper published in the American Journal of Human Genetics proposes another gene called ATRIP or ATRIP, which is a variant for breast cancer susceptibility. This was based on a study that was done on women who did not have any of the known breast cancer associated gene variants like the BRCA gene that we talked about. A team of Canadian and Polish researchers led by the University of Toronto completed this study by compiling data from 510 women from Poland who had a strong family history of breast cancer, but none of the confirmed moderate to high susceptibility breast cancer genes. ATRIP is a step in the much larger picture of DNA repair. According to oncologists, when a cell duplicates, this gene protects against mistakes at that stages of DNA replication. Someone with the ATRIP gene mutation will be more susceptible to this replicating errors. As we know, for a cell to become cancerous, it needs to duplicate at a very fast rate, and the DNA repair genes are important to prevent that. So, ATRIP plays a very important role in that, along with most of the hereditary genes that are known to be linked to breast cancer. These are also part of the DNA repair system. A loss of function or mutated variant in any of them increases the risk of developing breast cancer. ATRIP mutation is less common when compared to other hereditary genes which are associated with breast cancer, but it has been found that a person, if they have a mutation in the ATRIP, they are significantly more likely to develop breast cancer. This discovery could also explain why scientists frequently encounter patients where breast cancer runs in the family, but none of the family members have well known gene mutations connected to breast cancer, such as the BRCA1 or BRCA2. Even though the potential role of ATRIP may be small in the overall number of cases, every case of cancer that can be narrowed down to the causal mechanism helps in clinical prognosis and prevention. These findings could someday have implications for the prevention and treatment of breast cancer in certain families. This was a quote by Dr. Mohammad Reza Akbari, the study's principal investigator and a scientist at Women's College Hospital in Toronto. The discovery of a previously unknown risk factor in this study is now the starting point for the next, as more research is needed until a cure is found. So, as we can see, Even though we are finding newer and newer mutations and research is going on, there is still a larger event that comes up, or a larger play that needs to take place whenever a cure can be found for the cancer, right? So to drive this point further, today we have with us Dr. Emily Banerjee, with whom we will discuss the importance of genetic screening in the context of cancer risk assessment. So, Dr. Emily Banerjee is a certified genetic counselor by the Board of Genetic Counseling India. In addition, she is also a guest faculty in the Department of Genetics, University of Calcutta. She is a life member of prestigious societies like Indian Society of Human Genetics. She is also the zonal head East Zone in Lifecell International Private Limited, and is associated with various health facilities and fertility centers across eastern India to provide genetic counseling in different branches of health sciences. Having been a student of genetics herself, she has a keen interest in reproductive genetics and neuropsychiatric genetics. She has published her papers in reputed international journals like Molecular Neurobiology, American Journal of Medical Genetics, Neuroscience Letters, etc. Welcome, Dr. Banerjee, to our event, and we hope to learn from you a lot today.
Thank you so much for a beautiful introduction. And it's a noble cause. I'm very much delighted and happy to be part of this program. Thank you.
Thank you, Doctor. So, before we start, we just want to understand what is meant by genetic screening.
Yeah, it's very important to understand that genetic screening is like a checking test. Few people are there in our society who are present. They are having increased risk of developing any genetic disorder. We need to bring them to the treatment by checking them, by screening them, by informing them that you are having this much risk of developing this disorder. And there are few people in our society who are not having any kind of abnormalities to develop a genetic disorder, but maybe someone in their family they are affected, more than one individual of their family suffering from one particular kind of disorder, and they are very much anxious that they may also develop the same kind of genetic disorder. And when we are checking them, screening them, we may found that no pathogenic or likely pathogenic variant present in them, so we need to inform them that they don't have any risk of that. So screening is having actually two type of results. One, few peoples are there who need to bring to the diagnosis and to the treatment. We will bring them to the treatment, we will inform them and all these things. And few people are there who need to not to be anxious about the development of any kind of disorder, so we will give the happy news to them that you don't need to be conscious, but lead this kind of lifestyle, and all these guidance we can give through genetic counseling.
Okay. You used
So
a
genetic
term, Emily,
screening we can
called.
do for cancer and other different genetic disorders.
Okay. You used a term, Dr. Banerjee, called pathogenic variant. Can you explain that a little bit more? It's a scientific term, I know, but for our audience to understand.
Yes, yes. Why not? Why not? I should. Pathogenic variant usually we call those genetic variant. Genetic variant are those in our DNA. Usually four type of base pairs are there: A, T, G, C, adenine, thymine, guanine, cytosine, and we are having different variation like CAKE. It means cake. When I am changing this A to O, COKE, it is going to it meaning is getting changed. Like that, in DNA sequence also, nucleotide sequence, we are having few variations. Actually we are having a lot of variations, but all of them are not resulting to a change in the protein production by changing the amino acid. Only few variations are there, which are by changing the nucleotide, it is resulting in a change of a amino acid production by changing the amino acid, or it is getting changed to a frame shift variation, or a stop codon is coming in the way. So it is actually the protein production is getting affected somehow. And this kind of variation, in most of the cases, when we get different evidences that this variation is causative of a particular kind of disease phenotype, then we we report that variant as a pathogenic one or a likely pathogenic one. Am I
Okay.
clear?
So
I
to
don't know.
paraphrase, yes, yes, completely. Thank you. And I'm just paraphrasing what you said. So there can be several mutations that happens in a protein or DNA, but not all of them will be causing disease. So
Yes.
only a few will be causing disease, and those we call as the pathogenic variant.
Actually, there are different criterias for declaring a variant as a pathogenic or likely pathogenic one. ACNG guidelines are there. So
Mhm.
we need to have a very low allele frequency, minor allele frequency of that variant. You need to have a direct association with the disease. Phenotype genotype correlation should be there. It should be a conserved one. So there are different criterias based on which databases are there, like CleanWare, where we can report a variant as a pathogenic one or a likely pathogenic one.
Okay, understood. Fine. Who all can opt for a genetic screening? Like, should everyone do it, or is there a specific risk factor group who should particularly do it?
Mm, everyone can do it, but it is I cannot say if any one individual wants to do that, because in preconceptional stages, premarital stages, they can do, but preferably the individual in which there is a family history of more than one individual being affected with same kind of disorder, their first degree relative or second degree relative, like grandfathers, grandmother, cousins, sisters, they are affected with same kind of disorder. Then we will obviously suggest to them that they should opt for genetic screening. And in case of cancer, there are certain criteria. You know that all type of cancers are not hereditary. The cancers which are having hereditary base, uh, in those cases, we will recommend for genetic screening. And for other diseases, there are so many diseases which are having polygenic basis, multifactorial basis, and monogenic ones. So, depending on the mode of transmission, the reason, genetic base, we recommend actually. Then, who should be the first one, preferred one to go for genetic screening, who may avoid genetic screening, that we can refer to them and we can inform them, and after that, they can take the informed decision whether to proceed
Oh,
or not.
okay, so you say that personalized risk assessment for cancer can be done based on their genetic profile.
Yes, it can be done. It can be done. Obviously, it can be done. That is, how many we need to get a detailed family history. Detailed means at what age it was detected, who are the individual, what is their relationship with the affected individual, whether any kind of genetic test already done in the affected individuals or not, whether like in breast cancer, whether bilaterally the organs are affected or not, whether in any individual, in any single individual, multiple kind of cancers are there or not. And there are also few type of congenital problems, like Cowden syndrome, Lee-Fromeni syndrome, and we call it another one, BWS, Beckwith-Wiedemann syndrome. All these congenital cases, there is a possibility of developing cancer later in their lifetime. So in those cases also we can guide when to opt for a genetic test, and what will be their decision. All variant are not pathogenic, all variant are not disease causing. In case of all variants, the penetrance and expressivity are not same. So getting anything in their report, they they don't have any need to be anxious. So interpretation of the result, personalization of the treatment, everything can be done.
Okay. And like you said, if there is a family history, then the implications for the children or the sibling, this becomes more important for genetic profiling, right? I have interacted with few cancer patients, and their son and daughter are now anxious that whether they should do the genetic testing because their father had a certain type of cancer. So these are some things that usually bother the caregiver of the loved ones. So I think doing the genetic testing can certainly help them clear this anxiety.
Obviously, obviously help them, because if they can know that this may develop in him or her, then they can take the precautionary steps. Because in most of the cases in our country now, what I came across, I don't know whether the data is exactly okay or not, the main reason of human death is cardiovascular disease, and after that cancer is coming. And in cancer, breast cancer is in now leading. So, and we
Yeah.
know there is a strong genetic basis in HBOC. So we need to know. If we can know, we can take the preventive cares. That is most important. Change in the lifestyle, the medicine, when to start the medicine, when to start the radiation, whether any surgery need to be done at timely. We can do that. We can stop the disease to spread. Actually,
So you
prevention
mentioned,
is always better.
yeah, you mentioned HBOC, that is hereditary breast and ovarian cancer, is it?
Yes, ovarian cancer. Yes,
Okay.
HBOC.
And these are the most common group where genetic mutation plays a part for
Yes,
females, I'm guessing.
yes,
What
HBOC
about
is
men?
there, and Lynch syndrome is there, HNPC that is there, and pancreatic cancer is there, prostate cancer is there. All these kind of cancers, they are having hereditary base. Pancreatic cancer, prostate cancer, HBOC, HNPC, all these are having hereditary base. Very well accepted genetic base is there.
And I'm guessing there are specific guidelines for these kind of genetic screening also for these
Yes.
diseases. You mentioned ANGC. Okay.
SEMG guideline is there, and the other RCOG guideline are also there. Actually, there are two main flow of guideline. One is from UK and another is from the USA. And from
Okay.
both the places, we are having specific guidelines. We are following that. And in case of breast cancer, colorectal cancer, ovarian cancer, prostate cancer, pancreatic cancer, in all these cases, hereditary. It may be hereditary, it may not be hereditary also. We need to test, we need to screen.
And based on your experience, how receptive are people to this idea of genetic testing? Do they come to you by themselves, or is it the doctor who is prescribing it to them?
uh, in case of cancer, if I specify, most of the patient come by themselves. That is my observation. I have find several patients. One day I was coming back from a hospital, and one individual suddenly called me and she told me, I got your phone number from the Google and I want a genetic counseling. Then I said, okay, okay, cool down. You were so much anxious. And then she said, no, I came to know my father is affected by uh, hereditary breast cancer, and I know that when the male breast cancer is there, there is a great risk for the daughters. I need to check myself. I have also two daughters, so please help me. I have received several phone calls like that from the patient themselves. I think in case of cancer specifically, if we say, people are very much anxious, and when now these days people are often there doing that Google. every time. And there is a
Yeah.
syndrome among people, Angelina Jolie syndrome. I am calling it as Angelina Jolie syndrome, because whenever there is thing, there is a actress, famous actress, and this thing happened. Okay, this helped in spreading the awareness. I also, but they are getting a lot more anxiety also, without any reason, without getting tested. That much anxiety, it is not good. They should just consult with the genetic counselor or a medical geneticist, clinical geneticist that we call. We will analyze their family history. It is not necessary that if any one individual or more than one individual is affected with a particular type of cancer, or someone already got affected below the age of 45 with cancer, that doesn't mean that he or she who came to me for the consultation, they will also get affected. If also they carry a kind of mutation, then also the penetrance we need to look for the expressivity, and we need to analyze that whether what is the chance when that will develop, and what are the precautionary factors that we can take, and we can make change. That should be
Oh.
prioritized.
So after the testing has been done, you definitely suggest that they should go to the counselor and not get anxious, so that they can get proper guidance regarding what they can do.
Yeah, they
Yeah,
followed all
that
those
makes.
things. And another thing is there, because I'm very much related with the reproductive field. When they came to know that this kind of pathogenic variation they are carrying, and they are very close to their reproductive age, they can do one thing nowadays. They can freeze their eggs, they can freeze their sperm, and for a healthy, later on they can plan for a healthy pregnancy with that, before starting the radiation treatment and all these things. This is also very effective if we opt for genetic screening for
Okay, yes,
future
that's a very.
use.
Yeah, that's a very useful information, Dr. Banerjee, especially if a person has already been detected with cancer and if they do a genetic screening. Uh, so, what do you think they should be doing with that report, or is there any need for a genetic screening after that individual has been detected with cancer?
Yeah, we need to, because cancer detection, the mutations are mainly we need to screen somatic cell line as well as in the germline. If it is in the germline, then we need to be careful regarding the next generation planning. If it is not in the germline, it is only in the somatic cell line, then we need to don't need to worry for the next generation. So if detected also, then also I think that they need to go for the screening, that what kind of changes is there. Is it somatic only, or it is no, along with somatic germline variation is also there, that we need to identify.
Okay. And somatic would be that are not carried forward in other next generations, right? These are not
Yes, yes,
using.
germline one that will be carried forward.
Okay, sure. Um, Also, as we saw in the topic that I covered earlier regarding ATRIP mutation, so identification of these new genetic mutations can help further cancer research and advancement. What is
So we,
your view on that, you being a researcher yourself?
yes, that will add a lot of value. And because uh, we have done research in CSIR institutes in human genetics division, we know that how the gene frequencies, the allele frequencies, it varies from population to population. So in different population, we need to know what are the genes which are responsible, what are the variation, and which variation, like a variation is A to G, and in our population, that G is the minor one, which is having less frequency in our population. It may be the causative one in another population. So population specific data to identify the novel variation, it always add value to the treatment of that particular identified disorder.
So these specific mutations that are identified, how do researchers get access to them? Do they come to you, genetic counselors, or is there a gene bank where the researchers can access these from?
Researchers, there are different databases are there, but in Indian databases these days they are developing. IGIB, there is a collaboration in DBT with an IBMG. They are developing those databases. That is very, very, very essential. And we are also reporting the variant which are getting in the diseased individual in our population, specifically the novel ones. We are also reporting. We means the diagnostic companies. We means
Hmm.
here not my diagnostic company only. All the diagnostic companies, they are publishing good papers in good journals, because only by publishing and reporting to the database we can help to proceed with the treatment and for further research also.
So for individuals who are coming for this testing, I think this is a great opportunity to leave behind a legacy, because if they provide their genetic information to these databases, that can someday maybe help in finding a causative or finding a medicine even for treating that particular disease.
Most of the cases what I have seen, that they agree to that. We need to take their consent, that without disclosing their identity, but we are using their genetic data, so we need to take their consent. And in most of the cases they happily give consent, what I have seen, that
Mm.
when we explain the thing to them in that way, this data will help to the future generation, will help our Indian population. Usually in most of the cases, 98% of the cases, but I have seen that they happily agree to that.
And this data that is shared is anonymized. I mean, the patient's
Yes, it's
individual
anonymous.
information.
Always, always, always. But we need to take the patient consent always,
Yeah.
before publishing anything, before reporting everything. We need to take their consent, but it is anonymous. We never disclose patient identity to anyone. Whenever we are presenting the data to the doctors, there also we need to. We cannot disclose patient identity anywhere. It is
Okay.
also written in the consent.
There is a question in the comment section, Dr. Banerjee. Then, how do patients react if they get their genetic report as positive? What is it from your experience?
Most of the cases, uh, at first they get depressed if they find anything in the report. Then when slowly, this is the job of the genetic counselors, that we need to make them understand. It is not always that the variant which may be identified in him or her is the, they need to be anxious about that or something. It may be that they not need to be anxious about that. We need to explain the things, and we always, I what I do actually, first I explain them the positive side, that for the detection, what they can take as a precautionary step, what good things can happen, that I explain to them. Most of the cases they accept it, they need to accept it, but it depends on the counselor, how they counsel the patient, how the information is going to them, how they are getting the news, giving bad news. That's actually the lesson that we are being taught in our genetic counseling thing. We need to learn that how to give that bad news. This is a bad news. Obviously if one is carrying a pathogenic variant which is increasing the risk of developing any kind of disorder in some individual, it is always depressing one. But we need to present it, we need to, everything has two sides, both sides, I think, the negative side as well as the positive one. I think we always need to focus them on the positive side of that,
And do
what
you
good
also work with,
happen.
yeah, do you also work with oncologists in this case when when a person has been detected with
Always,
genetic
always we
mutation?
do that, and we always prefer that if in the genetic counseling session, as well as the oncologist, the genetic counselor, and the patient, we can sit together. That always helps the patient and us also. In most of the cases, what we do, we sit along with the clinician. Initially, sometimes we counsel the patient primarily, then we sit with the clinician, and three of us together or patient family sometime together, we communicate with each other. They are also involved in all these things, clinicians. They
This is
recommend
such an
also.
insightful Yeah, this is such an insightful session, Dr. Banerjee, and I think we have so many more questions, but we are short on time. This is something that we have already reached a 30-minute slot, and I
Oh,
think we still
yes.
have more questions. Yes.
Oh,
But I'm sure we have more such things, more such sessions with you, so that we can cover more ground. If we have any more new insights, we can definitely have you back. So thank you so much for today. And this has been really knowledgeful information that we have had. Thank you so much once more.
thank you so much. And I hope that everyone will understand the importance of genetic screening, and without getting anxious, they should opt for that. If one or more individual are affected in their family with same kind of disorder, or any one individual is having affected by one or more kind of cancer at the same time, they should opt for genetic screening and get help from genetic counselors. Thank you.
Thank you. Thank you so much. With this, we come to an end to today's event. Thank you all for taking part in this engaging session. We look forward to seeing you again next week when we will have with us a very special person who has been through this cancer ordeal. Even though she now grieves her loss, she is determined to spread hope and positivity that she has learned through her personal journey. We look forward. I hope you will do too. See you next week. Have a great day ahead. Thank you.